Hello, thank you guys for joining my channel again. I will be discussing this Journal Club article which was recently published in Frontiers in Neurology on October 2020. The title of the article is Intracranial Arterial Calcification that relates to long-term risk of recurrent strokes and post-stroke mortality. Just a little background about this article. Intracranial arterial calcification is frequently observed on non-contrast computed tomography, which is the CT scan, which is a routine imaging and investigation for patients who come in to us in the hyperacute stroke setting, and we do a CT brain. Previously, the clinical studies found that a nearly 70% prevalence of cerebral artery calcification was present in Chinese population. There was a prevalence of over 80% among stroke patients, which was described. There was a population-based study in white individuals demonstrated the role of intra-arterial calcification in increasing the risk of a first stroke, which was called the Rotterdam study. This study is published in JAMA Neurology back in April of 2014. The highlights from this study was that it was a population-based cohort, and which was done between 2003 and 2006, a random sample size of around 2,323 stroke-free persons with a mean age of 69.5 was taken and underwent a CT scanning to quantify the intracranial arterial calcification volume. All these participants, they were continuously monitored for occurrence of stroke until January 1, 2012. So if you see that this recruitment happened between 2003 to 2006, and the follow-up period was back in till 2012. So it was a very longitudinally long study comparing, at least following these patients up for at least 10 years. uh, the main outcome measure which they were looking for was an incident of stroke. So their results were interesting. During 14,055 person years of follow-up, that was attributed which was calculated by the total number of patients who uh, were enrolled in the study, which was around 2,323. There were 91 participants who had the stroke, of which 74 were ischemic. Larger intracranial arterial calcification volume was related to a higher risk of stroke, independent of other risk factors including cardiovascular risk factors, ultrasound carotid, plaque score, calcification in other vessels. When they fully adjusted this for the other contributory confounding factors, they found that the hazard ratio was around 1.43 in this study, and the intracranial carotid artery calcification contributed to 75% of all strokes. For aortic arch and the extracranial carotid artery calcification, this incident was only in around 45 and 25% people, respectively. So it was very interesting considering the Rotterdam study and the results which they finally came up with after 10 years or so of this follow-up was that intracranial artery atherosclerosis is an independent risk factor for having future strokes. This On the right side of the screen on the slide, there's like this interesting formula which is predicted absolute risk, which they calculated by this formula in their study. This is the CT scan image of intracranial arterial calcification. This is an axial CT in which the white rectangle marks the region of internal carotid arteries. And you can see the Petrus course of the intracranial carotid artery, which is present on the slide B. The red areas, they mark this intracranial calcifications. This was interesting results from the Rotterdam study. There were three models which they generated in this study. Model 1 was adjusted for age, sex, and scanner type, and it had a hazard ratio of around 1.51 in the ischemic stroke group. And the Model 2 was adjusted further for obesity, hypertension, diabetes, hypercholesterolemia, low density lipoprotein, cholesterol, and smoking, and that hazard ratio was around 1.53. And Model 3 was further adjusted for ultrasound carotid plaque score and computed topography, assess calcification volume in coronary arteries, aortic arch, and extracranial carotid artery bifurcation, and the hazard ratio came out to be 1.39. So this was the background before this study came in. So this is the current paper which we are going to discuss today, which came in published in Frontiers of Neurology in October 2020. Their methodology was that this study was a part of Prince Wales Hospital Stroke Registry, which was present in Hong Kong. The recruitment method was identical to a population-based study. So because it was a sort of a tertiary care center, so most of the referrals they came from even rural areas. The stroke referrals were coming to this hospital, so that's why they kind of thought that their study had the population-based study dynamics. Data they analyzed was between 2004 March to 2005. Both TIA and stroke patients in their study were recruited, and the follow-up regularly was done till June 1, 2016. So this is an 11-year follow-up in this study as well. Interestingly, ischemic stroke or recurrence and post-stroke mortality were the main outcome measures which they were looking for. The exclusion criteria included the venous infarcts, intracranial hemorrhages, subdural hematomas, and subarachnoid hemorrhage. Other potential causes of intra-arterial calcification such as hyperparathyroidism or end-stage renal failure, they were excluded. Patients who refused secondary prevention by antiplatelets or anticoagulant therapies were also excluded. Obvious artifacts in the CT images that were all not measurable for IAC were also excluded from this cohort. This is an interesting criteria where this is the operational definition of how they assessed the intracranial arterial calcification and how they scored it. So IAC was assessed by using quantitative Agatston score, found that IAC was closely associated with cerebral artery stenosis and intracranial microembolism. They acquired the 3D CT images with the IAC, which is the intracranial arterial calcification segments, which were kind of reconstructed at 3 millimeter intervals, and they used MATLAB further to generate these scores automatically using a custom-made program with the Agatston algorithm, which was incorporated into the MATLAB. IEC was defined as hyperdense foci with attenuation number of greater than 130 Hounsfield units with any of the following cerebral arteries, either right or left of intracranial ICA, ACA, MCA, PCA, vertebral arteries or basilar arteries. Weight value further was divided into these four groups. One included people who had a Hounsfield unit score of 130 to 199. Second one was 200 to 299. Third one was between 300 to 399, and fourth was 400 Hounsfield units or greater. So the scores greater that deciphers to increased intracranial arterial calcification score. Statistical analysis they used to measures, which was the Cox proportional hazard regression model, to investigate the association of the presence of IEAC and IAC Agatston score with stroke recurrence and post-stroke mortality. The second one was the Kaplan-Meier curve and log rank test for estimation of stroke recurrence and post-stroke mortality for patient groups with higher greater than median score or lower less than median score, IAC gets some score. This is the baseline characteristics of the cohort of patients which were included. Age was, you can see, 71.6 was the median with the deviation of 12.4. Sex, 50.3% people were of male sex. Hypertension was present in 72.5% people. Diabetes around 33%. Hyperlipidemia in 51.9. Atrial fibrillation in 21.3. Ischemic heart disease 14.1. Two or more ischemic stroke history in around 24.5% people, having ever smoked 28.1% of the people, TIA in 16.1% of the people, and ischemic stroke in 83.9% of the people. Dose classification divided these strokes to be large artery atherosclerosis, which were 40%, small vessel occlusions 28%, cardioembolic strokes 21.3%, other determined etiologies around 1.7%, and undetermined etiologies 0.9%. Two or more causes that were identified included 7.4% of the cases. Further IAC or intra-arterial calcification characteristics: presence of IAC volume, which was around median was around 169.3, and the range was between 40.9 to 431. And IAC Agatston score, median was around 64.8, and range was between 14.8 to 180.7. The table 2 within this table shows the prevalence of intracranial arterial calcification in 694 patients. Intracranial ICA calcification was present in 641, AC in 0.1, MCA in 3.6, PCA 0%, basilar artery 2.9%, vertebral artery in 39.2% patients, and any other intracranial arteries, they were like 643 patients. So this was the results. So if you could see, they generated these two models. And in the first model, they showed the crude unadjusted effect estimates. In the model 1, you were able to appreciate a hazard ratio of 1.80 with a p-value of 0.107. In the model 2, this hazard ratio is around 1.23, which is adjusted. It is adjusted for age, sex, hypertension, diabetes, AFib, hyperlipidemia, ischemic heart disease, two or more ischemic stroke history, and ever smoking. And the p-value was 0.599. With this similar model, the model 1, when they were able to further cross it with the standard, with the Agatston score per one standard increment, they were able to find out this statistically significant value. Model 1 showed a hazard ratio of 1.40, which was highly statistically significant, and model 2, which was adjusted, was also very highly statistically significant with a p-value of 0.005 and a hazard ratio of 1.30. So these models are actually saying that in people who have a higher IAC calcification score, they are at a more likely per statistical probability that they might have primary outcome, which is the stroke or morbidity or mortality. So that's a 1.4% more higher chance as opposed to 1% in the normal person who is not having a higher score. So that's how it what it correlates to. This is also a very interesting slide in the ischemic stroke group. What they did further was that they divided these stroke types depending upon the dose classification, and what they found was that the total number of patients who had the stroke out of 694 were 22.5%. with a hazard ratio of 1.40 and a p-value of 0.00. In people who had the TIA, the recurrence was 20.5% with a hazard ratio of 1.27. The p-value over here was 0.237, which was not statistically significant. Stroke and on the right side, these are adjusted hazard ratios as well, which are further divided, and their p-values are also further checked. In the ischemic stroke group, there were 582 patients, and 133 had the recurrent primary outcome, and the hazard ratio was crudely was 1.41 with the p-value, which was highly statistically significant. Their adjusted hazard ratio was 1.39. The p-value over here was also statistically significant. In the ischemic stroke group, the further dose classification division among these ischemic stroke subtypes: large arterial atherosclerosis, there were 233 people who were enrolled initially and had a recurrent event in 54 patients, who accounted to 23.2%, and the hazard ratio was 1.30, which after adjustment was 1.20, and both adjusted and non-adjusted did not match the statistically significant value. In the small vessel occlusion, however, this is a very interesting result, that they found that once out of 167 patients who were enrolled, 20.4% or 34 people had the primary outcome measure, and 1.48 was the hazard ratio who crudely, and adjusted was 1.67, and both these values were statistically significant. The cardioembolic group had 124 enrollments, and 27 had a stroke, which accounted for 21.8% of the population of this cohort, and the crude hazard ratio was 1.57, which was not statistically significant after adjustment either. 1.06 was the hazard ratio afterwards. So the main important result out of this was that ischemic stroke in general are more related to a higher risk group, and when they did it in absolute total, out of 694 patients, 156 had the primary outcome measure, and the subgroup analysis with the small vessel occlusion was also highly very statistically significant. So that translates to people who have a higher IAC calcification score. They might have more recurrent small vessel the small vessel occlusion enrollment patients might have a higher chance with the higher IAC score that they will have the second stroke more highly likely, with a hazard ratio of around 1.67 adjusted. This is the Kaplan-Meier curve. If you can see that the green line here, it denotes the higher score group, and the blue line over here denotes the lower score group. And you can see that there is a widening of this gap as you go, as these patients were followed up over 12 years, and the higher score patients were going downhill more, as opposed to those who were having a lower score. So the results in this graph were: in a higher risk group, the risk of developing recurrent stroke was 9.2% at 1 year, 21% at 5 years, and 25.6% at 10 years. While for patients with lower IAC Agatston score, the risk was much lower. That was 6.9 at 1 year, 13.5 at 5 years, and a total of around how much was this? Yeah, a total of around 15 to 16% afterwards. So coming to the critiques, the limitation of the study included overestimation of extent of vascular calcification in the CT imaging, the absence of stroke severity on admission, the absence of treatment for stroke, single-centered study, and the sample size especially smaller among different stroke subtypes. So that can also lead to the unsignificant statistical results, which were found in the subgroup analysis after post classification was applied. Uh, in this cohort, the conclusion is that IAC was associated with the risk of recurrent stroke and post-stroke mortality during over 10 years follow-up. In addition, index small vessel occlusive stroke patients who had a higher IAC score were particularly vulnerable for another stroke. Among further stroke subtypes, IAC is associated with recurrent stroke among small vessel occlusive patients with indicate chronic calcifications detected in large cerebral arteries that may have potential on the cerebrovascular beds extending to small vessels. So, in summary, this paper has found an association between this intra-arterial calcification after a stroke to have a higher risk of having a recurrent primary outcome measure, which could be a recurrent stroke, mortality from stroke-related causes, or a recurrent TIA. So this was an interesting paper. I would appreciate if you guys can leave your feedbacks on my channel. Thank you very much.